Well, good afternoon, everybody, and thanks for joining us. If you're wondering where you ended up, you're at the CAF COVID Weekly Roundup. Today is August 14th, 2020. It's 1 o'clock in the afternoon. And my name's Jason Belden. I'm the Director of Emergency Preparedness for the California Association of Health Facilities. And today we were planning on having Patty Owens join us, CAF's Director of Regulatory Affairs, but Patty got pulled away on a call with CDPH, so she's on a call with CDPH at the moment. So we'll definitely brief you guys as to the results of that call, but they were going to discuss a potential AFL that's going to come out. So, all right, so let's hop right to it. We've got some fairly dense material. I know there's questions about antigen testing. There's definitely questions about PPE after Cal OSHA's statements on the HSAG webinar on Wednesday. So we've received a lot of questions, and hopefully we'll have a few answers for you or clarifications. Also, maybe some some tips on how you can stay compliant by what Cal OSHA said, and what are best practices around that. And then we'll talk about some of the other equipment they had mentioned, because they mentioned some equipment as alternate methods of PPE, but they did not display what those were or explain them. And I know they're going to have a webinar on it. I just wanted to give you some little background information before you get on that webinar to learn about that stuff. So let's get started here. So in terms of the AFLs that came out this week, none of them were, I will say, earth-shattering. We got a revision, our fifth revision, I think, of the update to visitation. This revision really only clarified that a doula may be permitted during labor and delivery. I did not see any marketed difference based on a previous AFL for long-term care. The previous AFL had addressed the nursing students. So if you're interested in that, the language is still there, and you can click on the CDC guidelines for the return to work criteria for, the nursing students have to meet the same return to work criteria as a regular staff member. And then 2065, I don't have to probably tell you guys much, because much of the state is under a heat advisory. But CDPH updated their AFL for heat advisories. The content of the AFL was not that much different. It just really kind of clarified what the expectation is for you guys if you lose air conditioning, and some tips or tricks that you might think about in order to maintain a safe environment, even with the loss of power. So, and then they did clarify that facilities must report extreme heat conditions that compromise patient health and safety. And I would think that if you lose power, well, we already know if utility failure is one of those conditions that you'd want to report to the district office. So if you suffer a power outage or utility failure during this time, you definitely want to let those folks know. All right, AFL 2064. Now, I'm not, I don't know anything. Well, I'll be frank, I'm ignorant when it comes to the PBJ system. So Patty was planning on discussing this a little bit, but this AFL is just kind of a reminder of what she had previously talked about for the PBJ system, and that goes into effect on the 14th. And then AFL 2063, even though we talked about this slightly last week, I know Patty went in depth, a number of people have reached out and said they've gone to that Risk and Safety Solutions website and signed up to, to get an authorized user account, and they're having like week-long delays in getting people signed up. No surprise there. But what we want you to do is, you guys as providers, if that is your experience, please let us know in the district office that your facility is in, so that we can address it with those folks and let them know, we're still seeing issues with the sign up process, and that may affect how well we do this when it rolls out. So, all right, and The second thing I wanted to talk about, guys, and please, if I sound like I'm frustrated, please, if you're doing these things, well at your facility, please, I'm not speaking to you, so don't take this personally. But we actively encourage CDPH and with anybody that we know of that has an interface with long-term care, we ask them for feedback on what their experience is. And one of the main things that we've talked to CDPH about is what are the kind of the things that you see folks not doing so well out in the field. And I realize there's a couple hundred of you on the phone, and this is not may not apply to all of you. But full-time infection preventionists is the number one thing they go out and find folks have not addressed. Even if you're, delegating the duties among multiple staff rather than having one person do that, those practices and those scopes and those job functions need to be clearly delineated so that the surveyors can see the actual time that person's spending on infection prevention versus their normal course of work. Family communication. This one strikes home for me as, I think a lot of us have had family members in nursing homes, and, and maybe as an industry, we don't do so well on family communication. And I realize that the map is all over the board with this. But this seems to be consistent regardless of where I talk to somebody, regardless of the family member. Forgive me, there's a plane flying over my house. But we're getting consistent feedback from family members that they're not receiving callbacks. And I just want to make it clear the expectation under the mitigation plan would that you would have a designated person that would be responsible for daily communications with the family members, the residents, and the staff. So whatever you need to do to strengthen that family communication, these are the stories that will define us. We've all struggled with infection prevention and control. We've all struggled with appropriate PPE usage. We've all struggled with wrapping our heads around staffing zones and donning and doffing, and all of these other things that we weren't great at that we had to become good at. So the one thing that has gotten what seems worse is the family communication, and that just can't happen now. It has to get better, not worse. It has to be more transparent. It has to be more frequent. And I've talked to a number of administrators to ask for what are best practices you guys are using, and what are things that you can do rather than add this as duties as assigned for yourself. Who can you divide this up to, and what are the procedures you can do, and what are some technology solutions that will help you with that? One of the big ones, obviously you probably even heard this from through your own infection prevention survey, but appropriate PPE usage, and that's based on the staffing zones, and then the donning and doffing process, which is more important than maybe we might give it credit for. So under the full-time infection preventionist, this is still the number one thing that CDPH says that's not being addressed, or it's being addressed kind of haphazardly. So whatever your policies are and your job descriptions and the duties that you have these folks set aside, make sure that it's clearly delineated. That was the most current feedback from CDPH as to what within that that requirement that folks are struggling with. Now, if you've not hired anybody, well, I'll just say you're definitely going to get a deficiency for that. But it's we've talked to other folks about, well, gosh, these folks don't grow on trees. Where are we going to find them? And many of the providers that I spoke to and said, look, I've taken one of my existing staff and I've up-trained them. I send them through the course online, And that's going to be my second infection preventionist, and they're going to work at this time. And my point is, they, rather than look outside and go, gosh, there's nobody out there for me to hire, promote from within somebody that you think can dive into this. And that was the best practice that I had seen, because a line worker or an LVN or an RN might be easier to find than an RN with a specialty in infection prevention. So that was kind of the best practice that was mentioned. And certainly if you guys have other ideas about how to address the full-time infection preventionist with existing staff, and what was the model that you used, and who did you pull from, and what seems to be working the best, we'd love to hear those stories. We definitely want to hear from administrators about what were the struggles with that, or do you continue to struggle with that? So, and I'll talk about kind of a request for you guys after this. Family communication was the second piece. And I mentioned that the mitigation plan calls for a dedicated person, or a designated person, I should say, not a dedicated person, but designated, a little bit different. One of the things that we should all shoot for, and I didn't have to ask anybody this, because this is just basic customer service. If you receive a call from a family member, there's no way that should go past 24 hours. I'm sorry, even if they're difficult and you don't want to talk to them, it's important that we do that, because that's what defines us in the media. Those are the stories when we get interviewed, we get confronted with. We have to answer for that, and we have to be really good at that. We should have the family singing our praises and not complaining about their experience. That's what needs to happen, because we need the families to know we're doing everything we can to keep their loved ones safe. Outbound messaging. So one of a number of providers I talked to, and I'm not going to give you a specific technology platform in which you can use this, but you definitely can use outbound messaging, where you can record in your own voice a daily message, and that message would go out to everybody on a listserv, and it would be sent on a daily basis. You could change the message daily and record it in your own voice. It takes a fraction of a minute, and you can, have all your outbound messaging done in a fairly short period of time. And I think that's important, especially if you want to just general announcements that everybody's going to get, not personalized messaging, obviously, but this is what we're going through. This is our number of positive cases. This is our plan. This is a status of our visitation at the moment. All of those things could be included in the outbound messaging. You get to determine that, but I think whatever the modality you use to do this, it's important that those folks feel like they're kept in the loop, for sure. We need to look, if you're not doing this, we need to look at the inbound procedures for calls. This is, for years, I've spent trying to circumnavigate the complex process of getting to an administrator from when I called the main line. And if I'm struggling with this, other folks are struggling with this. So what is your inbound procedure for folks that are looking at getting information on their family members? So whatever those are, those procedures need to lead to an outcome. Those procedures need to lead to somebody taking accountability and responsibility for that call. And whether that's somebody that's answering the inbound calls, which is probably unlikely, it may be just taking a message, giving them the name of the person that will be calling them back. But we want them to be able to understand. We hear their message, we understand their message, and this person is going to be giving you a call back within X amount of time. And that's just good customer service 101. If we can do that, it will vastly improve the stories that we hear in the media about folks not being able to get a hold of their family members. Because I've heard 2 weeks, because we have patient advocates that we speak with quite frequently, family members and things like that. So it's not good across the board. Otherwise, I wouldn't hold you guys out and just say, well, I know you 200 that listen to these webinars with regularity. This is probably not you. but at least look at those kind of things and make sure that everybody is doing that. And the most important thing is proprietorship. Like, own that, the responsibility to have good communication with your family members. You know, I always encourage folks to treat it like it's your own business. And if it was your own business, what would you do? And so that when you train your inbound staff or folks that are going to answer those phones and communicate with people, I tell you, people will really appreciate that. They'll appreciate the name, the personal connection, the commitment to transparency, and the message of how well we're providing care for their loved one. So all of those are incredibly important, and they will absolutely define us if we don't do it well. Appropriate PPE usage. This is, you know, we'll talk about the PPE in a second after OSHA dropped a bombshell on the webinar the other day. But source control, many stories of nurses walking in for their shift, or any staff, not just nurses, but in one instance a DON, but staff not walking in the building wearing a mask. And that's, and under no circumstances is that acceptable. And frankly, if folks are doing that, it's just silly. I mean, I don't know where you live, but when I go to the grocery store, there's big darn signs on the outside that says you cannot enter without a mask, and that should be the message to every one of your staff or anybody else that comes to the front door. No mask, you don't enter. Period. Inappropriate PPE by cohort zone, and it seems to me the most common thing they see is the use of well, they're not using full precautions in the transition area or the yellow zone or whatever you want to call it, the observation area. Not wearing full PPE in that cohort zone, and that's super common. I think we're starting to get a handle on that, because I know that they've answered that question a number of times on multiple webinars. So I think folks are starting to get the message, but it's definitely, it's hard and fast, full PPE on any of those folks with unknown or exposed, as well as obviously the red folks. Staffing zones, and this one kind of drove me nuts when they answered this on the question yesterday, but I will say that one of the most common observations from the survey staff, and not always correctly, is that that you should be staffing each one of these 3 distinct zones separately, with separate break rooms and separate everything. Well, if we lived in a perfect world, that would be great. If we lived in a perfect world, we do 4 distinct zones, and we would staff them all separately. We don't live in that world, and that world does not exist. What exists is the fact that you're going to have to share those staff between cohort zones. How can we limit the exposure risk? Now, I will say, if you have 3 cohorted zones with full staffing on each one, that's complete to each one of those staffing zones, kudos to you. I don't know how you did it, but please share that experience with us. Maybe you already had an existing extra staff that you could dedicate it to that, or maybe you drew down your census so much that now you have enough staff to staff 3 distinct zones. But that is the exception and not the rule. And when they answered that question on the call yesterday, that was, at least they didn't make that as clear as they should. But I give them, you have to understand, they're infection preventionists, and they don't really spend much time working in the operational side of nursing homes. So they don't know what the staffing looks like. So they're answering the questions based on best infection prevention and infection control guidance. If you cannot do that, which we know most of you cannot do that, their suggestions are to minimize the movement to the extent possible and to combine care activities. And I even heard another kind of suggestion where the shifts are, portions of shifts are divided into one cohort zone, and you may be able to do that effectively. I'm not sure. That's highly dependent on you, but if you have best practices, gosh, I sound like a broken record, but we want people to share. We have a disaster advisory group, which a number of administrators across the state sit on the advisory group. And when we sit and share best practices across providers in that kind of environment, every one of them says, I learned something new today that I didn't know before. And I'm not saying that you need to join that group. I'm just saying that the sharing of best practices, because we don't know what we don't know. And unless you're in that other building to see what they're doing as a best practice, you may think you're on the best path. But I want folks to get into the habit of sharing these things with each other if we can. It's certainly gotten better in terms of sharing best practices or suggestions by the survey staff, which is great. And we want them to encourage that as well. My encouragement to CDPH would be, rather than say you must do this, say, hey, look, I know a provider that's doing it this way. If you did it that way, would it be safer? And that's really the question. And we want the surveyors to kind of get into that kind of mode of counseling folks because they can see 30 buildings and they know who's doing it good and who's not. So we should happily accept that information because they get to see things we don't. All right. And then good will and good intentions aren't precise. So that's great. We have goodwill and we have good intentions. I read an article earlier this week about the performance of the veterans homes, or specifically the veterans homes here in California, as it relates to mitigating the impact of COVID. And there were a number of kind of contributory factors. One, they're well funded and they fully staffed and they have an unlimited supply of PPE. It did not stop it from coming into the building, but it did stop it from becoming a huge outbreak. And a lot of those things have to do with their repeated practice of behaviors or activities that they want to model. And they practice frequently. They drill frequently. I have them on all my disaster meetings. They are the example of a military operation. And for those of you that have had CalMat teams or other types of teams from the military in your building, you know that's what they strive to be, is precise. They don't look for ways to get out of things. They just say what's next and let's keep going. And that's the thing we gotta kind of coach our employees up, our staffs up. We cannot let our guard down. One mistake really is a big deal, and it can lead to really adverse outcomes. So we need to be precise. That's all I'm going to say on that. But we need to encourage really kind of almost a religious process of hand hygiene, questions about symptoms checks, doing the line list, monitoring conditions inside the building. All of those things have to be precise. When we get lax with those, we get errors. And we're still seeing outbreaks. They're not as bad here in California, thank goodness for that, but it's not like they're going away. And folks, if you've had an outbreak and you think, wow, gosh, this is behind me, I promise you it's not. You still have staff that go out into the community every day. You may play hopscotch with this thing for the next 4 months. And so we need to be precise in our actions. All right, I want to move on to the antigen testing. PCR testing, I put the wrong word in there, PCR test reliability. I should have put PCR test availability is still highly variable based on lab and location. The reliability of the test is still good. We like that. The message, you got to keep searching. I didn't put the link to the testing task force website up here. Hopefully you guys are familiar with that. as you see this, kind of ebb and flow with the existing labs that you guys are working with, don't hesitate to reach out to other lab providers. If your lab provider is not taking care of the billing, but they're returning results back in 24 or 48 hours, maybe you go, well, that's meeting my needs right now. I'm taking it. I'm making all these payments. I don't know, but I will tell you that's not a common experience. Most of these labs are handling the billing internally, and so if you're still writing checks to these lab companies to do work that they should be processing the claims on the back end themselves, then you got to keep looking, keep searching. I wish it wasn't against the bylaws for me to mention names, but I have heard a number of labs that are consistently providing all of the necessary resources, including the reasonable timeframes to get the results back. So if that's not your case, keep looking. And these folks will ebb and flow. And when you make that call, you have no idea if they have the capacity to test 200 tests a day or 50,000 tests a day. Well, 50,000 is probably out of reach, but my point is you don't know what their capacity is. So we have to be flexible in how we address this, the current PCR tests and how we can get them. So, and then I want to talk about the two existing antigen tests that are being sent out. So we had originally really pushed hard to the state to get them to allow antigen testing. And one of the issues that has been brought to our attention is that these machines take a proprietary cartridge that the solution needs to be dropped onto the cartridge, and the cartridge is put into that machine. And that means there's one cartridge that works with that machine. There are no other manufacturers for those cartridges. Now they're being distributed through the main kind of distributor network. So if you think about the giant healthcare distributors, those are the folks that are going to be selling the test kits that go with the machines. Anytime we have a funnel where we're all reliant on one specific thing, we're going to run into the same issues with testing supplies that we are with PCR testing. You're still going to need swabs, so we'll be subject to those supply chain functions. And I'm not sure if the reagent that they use is the same as the reagent that's used for PCR testing, but they do use a reagent, which was another kind of failure point during this response. So while we think we're going to keep pushing for the antigen testing and to have it broadly accepted, what may happen rather than it being your primary modality is it may be your backup when the PCR testing is not working. And rather than an either or situation, it would be PCR first and then antigen second. And I think Los Angeles County they've given out a kind of a thoughtful guidance, or let's just put it this way. The guidance that they picked out was very specific in terms of when it can be used, and it doesn't have to be followed up with a PCR test for confirmation. I don't know if the state is going to go to that model or if other counties are going to go to that model, but if you're in Los Angeles now, Los Angeles says you can use them. If you watch the webinar, there's a very finite kind of space where you can use them where you wouldn't have to follow it up with a PCR test and you could be confident of the results. And that's for you don't have any positive cases. You call your lab says, I cannot get you the results back for 48 or 72 or 5 days or 7 days. And then you would kind of move into the antigen testing. And then on the antigen testing, if you have a symptomatic resident, somebody through your symptom checks has a change of condition, and now it prompts you to test. if you have one of those antigen testing devices, go through the training. I'll mention the training in a second, but once you have one of those devices for that specific person, if you get a positive test, you don't have to test them again with the PCR test, and you can immediately cohort them in your red zone if you already have one. And if not, then you're going to set up your red zone, get this person in it, and then begin response testing for the remainder of the facility. But outside of that small kind of narrow focus, most of the other tests, you could test a symptomatic resident. If it comes back negative, you still have to confirm that with a PCR test. You can test an asymptomatic resident or asymptomatic staff, but if you test those folks, you have to follow it up with a PCR test. So in those instances, it doesn't really make sense unless the PCR test is, you're not getting your results back for 10 days or something like that, because after 10 days, they've already met the criteria for removing them from precautions. So it makes no sense. I will say that if you have a symptomatic staff member who turns symptomatic while they're on shift. Now, if they're symptomatic and they show up at work, they should not be in the building to begin with. And if you have the test there, you could say, you know what, you got a fever, let's do a test here. At least I'll be able to tell if you're positive right now. And that could be a good kind of a help to keep that staff member working, because it does say that with symptoms, it's highly effective at determining whether those are an actual positive test, whereas they're concerned about the negative side. They want to confirm that with a PCR test. So if that symptomatic staff worker comes to work, they test negative, you still have to send them home because they have symptoms, and then you have to have them do a PCR test to confirm that negative antigen test. So there's a really limited scope in which you can use it in LA, and that's what you can use it for in LA. For the remainder of the state, CDPH removed their objection to the use of antigen testing, and they tied their use of antigen testing to CDC. Now, we discussed this last week. The CDC accepts that. The problem is CMS does not, and they clearly state that for diagnostic purposes, we need to do real-time PCR testing with a very high specificity rating. So until that barrier is removed, it might be that the remainder of us have to wait until that gets removed. But for those folks in Los Angeles, LA said, this is the guidance, this is what you want, what we want you to do, and this is the effective use of those devices. Supply side issues. I mentioned this. There's really only a couple of vendors. They are the largest vendors, but those distributors are going to be the only folks that have those test cartridges. And then we talked about what the best use is now if you have one. And then, gosh, I think I mentioned all that stuff. All right, there we go. All right. So this was going to be a Patty description. I'm not great at the 3-day stay waiver, other than to say that a colleague at the Hospital Association had reached out to ask why skilled nursing facilities were asking for written letters in order to take a skilled resident or a skilled patient from the hospital before the 3-day stay was met. And so the hospitals are telling them, no, gosh, that's been waived. And but the facilities are still sending letters to the hospital or telling the hospitals, we need a letter from the from their physicians stating they need skilled care. It has something to do with you're in a managed care area, and there may be issues with managed care paying that skilled rate. I don't know the entire issue, but if you the suggestion I would say is if you're having conversations with that discharge planner from the hospital, and the reason why you're asking for that is because of the managed care plans hesitancy to pay those skilled days. It's not, I know it's not a requirement for them to send the letter, but just say, hey, gosh, we won't get paid for that. unless we get that letter. So if you could be a dear and put it on your letterhead and send it over to me, it'll take you 2 minutes to do, and I will get paid by managed care the correct amount. So that would be my best practice for you guys if that is your situation. And if it's not, then don't worry about it. All right. So many of you guys were on the PPE, or well, it wasn't a PPE call, but it became one after that. HSAG had a webinar where they had Cal OSHA talk about, acceptable uses within a healthcare environment for us of PPE. I brought this up because many of you guys have printed this off, because I've actually seen pictures of it in buildings. It's the CDC guidance on preferred PPE use and acceptable alternative PPE use. And that acceptable alternative PPE use is no longer allowed per Cal OSHA as of August 6th. So if you're doing that and you have this sign up, take the sign down, or just leave the sign up with the N95 or higher respirator. And we'll talk about what the higher respirators are in a second. But this is something you probably didn't even think about, but if you've got these pictures strewn throughout the facility, let's make sure we pull these suckers down. All right, so the guidance that they sent out on August 6th replaces the previous guidance, which allowed a number of things that are no longer allowed. And I'm going to just read you a quote off the guidance, and you can roll your eyes as I read this. While supply chains for obtaining respirators are not fully restored, the supply chain of respirators for hospitals and other employers involved in patient care has improved to a point that prioritization of respirators for high hazard procedures or some other optimization strategies are not currently necessary. In other words, we no longer have to save conserve our N95s or our other respirators because the supply chain is restored enough that we can go back to disposable use of masks. And cue the eye roll now, but definitely I don't think that is consistent experience across the state, at least not given the folks that I've talked to. So I put that link on there. That's the entire text of the language. I'm going to talk about each one of the things that they encourage you to do first or in conjunction with PPE use. And we've talked about this multiple times, but engineering controls to minimize exposure and barriers are definitely required. Forgive me for a second. Is that? Hey, Jamie, can you see that on the screen there? I'm not sure if I can see that or not, or everybody else can see that.
Hey, Jason, it's Courtney. It is showing up on the screen for viewers.
Okay. All right, well, I'll try to make do here while we wait for Jamie to plug her computer in so the battery doesn't expire before this webinar ends. So engineering controls barriers are required for aerosol generating procedure, and there's a FDA guide to what those barriers look like and how they're applied. Ensuring source control, we talked about this, masks for everybody. Work practices that minimize exposure risk. Those are, we've talked about most of those. This is all listed and defined on that link that I handed out. PAPRs is the suggestion for, and I'll explain what a PAPR is. If you don't know what it is, we'll have a picture of what it looks like after this in a couple slides here. For aerosol generating procedures, and then it kind of goes in a prioritization schedule of what they recommend for those aerosol generating procedures. At a minimum, you got to have an N95 mask. That I think we all understand that, but and then training employees on additional precautions and changes. All right, so let me see if I can get this. I'm not sure if I can even advance the slides. Give me a minute.
Hey there, Jason. It's Courtney. Jamie's going to fix it right now. We apologize. One moment, please.
Hey, Courtney, well, why don't we do this? Are there questions that are already in the question and answer box? And then I'll come back to the slides in a second here.
Oh, there we go. I think it's.
Oh, okay, never mind. I'll go for it. I just didn't want to waste any time waiting. That's okay. All right. Let's see. All right. So acceptable optimization strategies to extended respirator use. Now, I'm going to use their terminology in here, and then I'm going to go, kind of show you what each one of these things look like. So when they put this as acceptable optimization strategies, they're kind of in descending order in which they want you to you address your shortage. And I'll just say right now that I don't think that's realistic. And I don't think that CDPH thinks it's realistic, and that's why they were kind of surprised on the call. Well, if you've got an Elastomeric half mask or full face respirator in your building or a PAPR, you're a big prepper, way past anything that's at my house. But I'll say it's highly unlikely that you will have these equipment. So it would be a massive upscaling of distribution of these supplies, which I actually think they are available. And since they're not disposable, they're meant to be reused. They're a good long-term solution. Possibly if we're required to stockpile long-term, large amounts of PPE, this will be something that we could probably move to mitigate that. But that's way down the road, and we're not talking about that right now, because each one of these masks has to be fit tested too. They're not the fit testing, it's the same qualitative fit testing, but they're different kinds of masks, so they'll fit folks differently. That's just a no-go. We're having a heck of a time getting our staff fit tested now. So I don't think any of these first three things are really all that reasonable. The problem is they've written this guidance as if this is the descending order in which you should prioritize the optimization of your use of respirators. I will say that they do allow extended use of respirators. That has not gone away. So if you're given staff a mask at the beginning of their shift, and as long as that mask does not become soiled, they can wear it for the entirety of their shift. After that thing's got to be either discarded or saved for decontamination. Now you can decontaminate these things and send them to Battelle, and when you get them back, you're going to put them in some kind of storage in case we run into this issue again where we don't have supplies. Outside of that, you're probably just going to throw them away. But and then there's respirators should be removed and carefully stored, yada yada, such as meals, restroom breaks. If you're doing that, you already know it. I kind of buried the lead here, but if you're reusing N95 masks and you did not already hear this, Cal OSHA said a hard no. Do not reuse them. Matter of fact, he doubled down and he said, I want you to go back to disposable use, one use and dispose of. Now, I don't know that we're there yet. I would love to be there. That is definitely the way they're supposed to be used. I don't know if that's realistic now. I think in the interim, if you're doing extended use, you're still flying, you're still compliant with Cal OSHA. Is our assumption. You're doing okay by Cal OSHA. It's just a reuse, and and also the use of surgical masks when you don't have N95s. Now, what does that mean if you don't have any N95 masks or you run out and you can't source any? Well, if you read the letter of the law, then you should not be having staff providing care in that environment unless they're protected. So my only option in that, if I'm an administrator, I'm saying, well, I can't put my staff in there. I can't provide care without staff. so I'm going to have to evacuate this person to the nearest place that can provide care. Hopefully it doesn't get to that point, but if you guys are ever that close, hopefully you've got a handle on when you're going to run out and you're not taken by surprise by this. But gosh, if something happens, you pop open, 3 boxes of N95 masks that you got from the county to dive into, and turns out they're all KN95 masks and you can't use those. In some weird off situations, you run into an emergency. If that happens, contact the district office in the Mohawk by phone. I don't care what time of day it is, you definitely want to let them know. All right, and so let's just show you a picture of what are these respirators that this gentleman's referring to. And if you're not familiar with this stuff, some of these devices are not traditionally used in healthcare, and some of them are. The PAPRs are definitely used in healthcare. They're used on decon teams. Whenever they have a decon exercise at the hospitals, you'll see their folks are wearing these PAPRs, and that's a powered air purifying respirator, and that's the one all the way on the right if you can't read the font there. But it's a white mask, full hood, and everything like that. Now that is what they're saying we need to do when we do aerosol generating procedures. So if you're doing those in your building, that's the recommendation. Now, remember I said that you can use an N95 mask with, well, obviously we're going to want some kind of eye protection for that person. There's some with like a shield and with a drape underneath it. You can use those on both the elastomeric and the N95 masks if you want to. The N95 mask is the third picture over from the right on the top. That's when an N95 mask, and the elastomeric respirators, that either the half mask or the full mask in the top 2 left devices. Those are the ones that I think they're really kind of pushing folks to, simply because they can be cleaned and used after each kind of use. They'll be able to use, and they have cartridges with inside, or canisters, depending on what kind you use, that filter out an equivalent amount of, it offers an equivalent amount of respiratory protection as an N95 mask. It just does it with a different kind of seal. And it is reusable, so you can decontaminate it, reuse it until those rubber grommets run out on the back or whatever. So you can see by having it as reuse, it's a potential long-term solution, but each person's going to have to be fit tested to those, and then they're not inexpensive, let's put it that way. So, and then the ones on the bottom, you don't have to worry about those. Those are more for fire service and other folks. So, all right. Well, sorry, I went back up. Cal OSHA is going to do a webinar on the use of elastomeric respirators in healthcare settings. I hate to send you guys to more educational material, but I don't know this content very well, and simply because we don't use elastomeric respirators in healthcare settings very often. So I will be attending, I will take notes, I will try to relay that information back to you if you're not able to attend. But if you are, that's the link to register for the webinar, and that's the time and date that it's going to be on. And then I did hear on the call that CDPH had encouraged folks to go through the MOAC process, and we definitely want folks to continue to do that. But if you're forced to ask for masks from CDPH, and they're part of that BYD mask shipment, what I'm hearing from some hospital partners is that the masks really come in one size, and it's really it's difficult to get a proper seal on those masks, and they've had really high failure rates on trying to get people fitted to those masks. One hospital said it was 50%, so 50% of the people could wear it and 50% could not. So if you ask for those masks, or masks from any government agency, I hate to be a hoarder here, but I would not wait until I'm out before I'm asking. I would keep a moderate supply of enough sizes that If you get a shipment from CDPH or the Mohawk or whoever you get the PPE from, you would want to have at least some to make up for if they didn't send you the right size. So that's kind of a best practice that you could, hold some back. I'm sure folks are doing this now, but if you're not, just think about holding some back in enough sizes that if you get a big shipment and they all come in one size and you can't use them, at least you have some for some of your other staff. So, and then I did not put this on here, but I'm going to put a link on the forum a little bit later, and this will apply to Los Angeles County only, but Los Angeles County has a purchase opportunity for facilities within the county where you can purchase a mask directly from the city of Los Angeles at their cost, which is 79 cents per N95 match, which is reasonable price given what we've seen nowadays. And I, either myself or Joe will put that on the forum shortly here. All right. So thank you very much, guys. Let's hop to questions. Courtney, do you have any questions?
Yes, we have some questions and comments. So let's see. We have a question from Calvin. He says, we might have supplies available for PPE, but at what cost, and are they reliable sources? So I think this is more of a comment, but that's a really good point, Calvin. Jason, do you want to speak to that at all?
No, let's hop to the next question. It was a good point. It's good.
Okay.
I'm gonna get to as many questions as I can.
Right. So I'll just remind everyone on the call, if you'd like to go ahead and put your questions in the box now. We have about 3 comments, so I'll go ahead and read those, and hopefully we get some questions in a minute or two here. So Roy had a couple comments. He said, it is not reasonable to not reuse N95s. There are no N95 masks out there in the marketplace. Also, those reusable elastomeric respirators have an exhalation valve, which is contraindicated. So it sounds like, Roy, you have a pretty good grasp on these masks here. Jason, do you have any comments on that?
Yeah, and I'm not sure if that person listened to the webinar on Wednesday, but he did talk about the efficacy of those masks with the exhalation valve, and they showed a study that had been done that they believed that it did not represent a material difference. And the study was a recent study, and I'm not sure, I'm not an expert in those things. I have to rely on the fact that when they made that recommendation, let's hope that they didn't do it without some real due diligence because of that exhalation valve. One of their recommendations was that drape that went over it or covering the exhalation valves. And I can't remember if he said it was okay to do it with a surgical mask. I thought it was just with that shield and drape get up that looked completely unreasonable. So.
Okay, we have one more comment and then a couple questions. Noah says, please encourage everyone to attend the Cal OSHA webinar and then bomb them with comments about the lack of supply.
Yeah. Yeah, I mean, it's a tone deaf statement right in the beginning that they're basing their assumption on a supply chain that we don't think exists. It may exist in spades in some areas, and the state may be sitting on 22 million masks, but getting those masks to you and making sure that the masks are effective for what we need them to be is a challenge, and it has been a challenge. But I will say that if you guys don't have masks, there are different modalities for you to get them. And I kid you not, I would be on a first name basis with my Mohawk, and I would be saying, look, if you don't have them, then you need to push this request up to the state because they're sitting on 20 million masks, and they told me to call you to call them. So, I mean, I would 100% doggedly address this issue with them. And I would not let go. I'd be like a dog with a bone. So I think you guys got to really attack that. Take every opportunity you can to get those resources. Next question.
I keep hearing about N95 fitting tests. Is this required for disposable face piece N95s that SNFs commonly use?
Yes, 100%. Initial fit testing of every employee that's expected to wear a respirator has to happen prior to them providing care. That's the rule. That's the law, and it's been in there for quite some time. So if you've not fit tested your staff and you're requiring your staff to wear N95 respirator, you're going to be in big trouble. I'm not joking with you guys. You're going to be in big trouble financially and liability wise. You need to have anybody you give an N95 mask has to go through the initial fit testing process. I can't be any more clear than that. I've said it on multiple webinars. We need to fit test our staff, and I see eye rolls going. I'm trying to find the fit test solution, or trying to find fit test kit, or I'm trying to find another company to do it. Throughout this process, we have underestimated the amount of just other stuff that needs to get added to our plate. And this is just an example of that it can't be other duties as assigned for somebody. Somebody has to take ownership of this, and they have to make it their number one priority. That's what you do. You figure this out and you get back to me with a solution. And that's what we have to, kind of get people to, is we want outcomes. We don't want goodwill or intentions or frustration. We want to put our feet in front of the other and get this stuff done. It's really important. We're trending in the right direction for California. As a state, we're trending in the right direction. We want to keep that up. And the reason why we're trending in the right direction is because we're doing all these things good. We have to stay with that kind of, we need to double down on all those things that we do well and continue to do. But if you're not fit tested your staff, as soon as you get off this call, you absolutely need to source a method to get your staff fit tested. Reach out to your fellow administrators or folks that you have gone to, have talked to over the years, and find a resource for that in your local area. Whether it's a company that comes out and does it, whether it's a company that trains you on how to do it, whether it's you buying the fit test kits and doing it yourself, all of those things are within your purview. I will say, if you hire somebody to do it, it's going to be really expensive. If you hire somebody to teach you how to do it, and then you do it yourself for all your staff, or have one of your staff members do it, then it's going to be much less expensive for you guys to do. Did we have any other questions, Courtney?
Yes, we have another mask question. Can you use valved N95s with surgical mask coverings for source control?
That I don't know. That you could make a great point, because they had originally said no, but I don't think that those N95 masks are allowed. I'll say it's a no, but I don't know, because it was a no before, and because of the exhalation valves, and now they're suggesting something with an exhalation valve. So I can pose that question. There may be something where they say, well, we want you to wear that face drape over the top of it. If you click on that FDA link, it's got a picture, and also that OSHA guy had a couple of pictures. They're the kind of goofy looking things with the big shield and almost like a curtain underneath that's like a bib or something. It's hard to explain, but maybe they'll say, oh yes, you can use them as long as you're using that on top of it. I don't know. I can find the answer for you, and we'll bring the answer next time. If I can get an answer from somebody at OSHA prior to that, I'll put it on the form. Any other questions, Courtney?
Yes, someone asked, where do we find the training to be certified for fit testing?
There is no certification for fit testing. So you just, training could be a 15-minute in-service from the person that you could. So what I've seen is, folks have either hired a contractor, or they found somebody from their hospital or from their local health department that would come give them a 10 or 15 minute in-service on how to do the qualitative fit testing. And so the qualitative fit testing is just a shield, an enclosed kind of hood that goes over the worker while they've got the mask on. And then there's a scented spray that's like a bitter spray. Well, they use different kinds, but that goes inside the air in the shield. But if the person can taste the bitter, then you know they don't have a proper seal. It's really not complex at all. I guarantee you that your staff could pick this up. Frankly, the learning how to use the antigen tests are going to be more complex than figuring out how to do fit testing. And I didn't even mention this at the beginning. Gosh, I apologize. That Quidel and both BD, Veritor, and Quidel both have 5-6 minute training videos that are really good on how to do the test. So if you receive the device, go watch that. It's pretty easy to follow, but that will be harder than doing the fit test. The fit test just takes time. It's time consuming. It's not complex though. You guys should be able to figure that out. All right. Any other questions, Court?
Someone asked if you could repeat those names of the fit testing companies you just mentioned.
Oh, I did not mention a fit testing company. I've been chided by for mentioning fit testing companies. Specifically, we have antitrust rules. I can't mention certain things. But in any case, if you just do a Google search, and frankly, leading up to that's what I had to do across the state, was do Google searches for fit testing employees, mobile fit testing, and many providers had hired that mobile fit testing come out just to give them the training on how to do the fit test. I don't want you to charge me $150 for every staff member. I just want you to teach me how to do it so I can do it myself. And that's what the agreement that they've done. And now what they paid to receive that in service by the vendor, I don't know, but I just know that that's an opportunity. But there are other free options. Local health departments and your hospital partners, if you have a good relationship with their hospitals, they do this. They do the fit testing themselves, so they know how to do it for their own staff. They should be able to teach you how to do it for yours. All right, we're a little over time. Did we have any other big questions, Courtney? I could go a little bit longer if we need to.
Okay, let's see. Someone asked, does anyone have best practices regarding messaging for staff about safe behaviors outside of work? Community transmission is still quite high in Los Angeles, and staff are gathering with people outside their household.
Yeah, and that's a great point, and one that was brought to our attention, oddly enough, by the legislature. And they had talked about in communities of color and lower income communities, maybe socially, we have different practices. I'll just say that. And what we want to do is we want to encourage a term called harm reduction from our staff. So we can't really say, hey, don't go to any public places, don't go to a restaurant, don't do any of those things. But we want to encourage them to model the behavior that they do at work when they go home. So physical distancing, frequent hand hygiene, staying out of public crowded areas. When you're doing your visitation with families or friends, you do those in an outside space, in a space that when you can respect physical distancing. We can't make people change the way they live their lives outside of work. And frankly, we can't change much about what they do at work sometimes either, but we need to encourage them to kind of model best practice outside of work, because it will affect their ability to provide safe care. And I think if you do that, the folks that buy in, they're going to listen to that. And then for folks that have those social networks in which it really revolves around being around each other, we need to do it in a manner that's as safe as possible. And so, physical distancing, source control, outside if possible, all of those things we can encourage our staff to do, and maybe even have a kind of a best practice outside of work. You guys can come up with other solutions for that, but it's a very valid concern, and one we should all counsel our staff on. So thank you for bringing it up. That's a great way to end our segue or end our call for this week. If I didn't mention it, the instructions for filing your CEs are on the screen. And as always, thank you immensely to Jamie and Courtney for putting this together, and forgive
Jason, I have one more comment.
Oh, sure.
If
Go
I
ahead.
could.
Yeah.
I got a couple questions about the LA antigen testing guidance. I put the link to that in the question box and also in the chat box. If anyone needs that link afterward, please email me. And then also I'd like to say that next Friday, the 21st, is going to be my last day at CAF. So it's been really wonderful getting to know all of you in the skilled nursing community. And if anyone needs anything from me regarding our grant program, or any questions you have about your CEs for this webinar, please reach out to me. But after next Friday, I don't think my email will be valid. So Jason will be your contact for that for now
Yeah.
until we bring someone in.
Yeah, CAL FIRE is stealing Courtney away from us, guys.
So again, thank you.
They're taking our top staff, but we will, don't worry, we'll be in good hands. You guys will be in good hands after Courtney's departure. And we want to say thank you, Courtney, for all the hard work you've done for the many years you've worked at CAF. Thanks very much, everybody. You guys have a great weekend. Talk to you later.